Ramanathan, one of our neurology colleagues. Dashi is an outstanding young clinician scientist who had a New Hamilton Farley Fellowship, did her postdoc in Oxford in the past couple of years. She's now a staff specialist at Concord and runs a neuroimmunology clinic. She's also a senior lecturer at the University of Sydney and has a translational laboratory and clinical research program at the Children's Hospital. And she evaluates antibody-mediated neurological disorders, including demyelination and autoimmune encephalitis. Dashi is the lead investigator for the Australian-New Zealand MOG study group. So, Dashi, she's going to tell us about advances in autoimmune neurology. Thank you, Dashi.
Thanks, Clement. Let me just... Is that on? Yeah. So I'd like to thank the Brain and Mind Centre for inviting me to talk a little bit about my research and our team's work. And today I'm going to focus on antibody-mediated neurological disorders. So in the last 10 to 15 years, there's been a real expansion of knowledge and the identification that some patients who have demyelination or damage to the myelin surrounding axons and neurons in the central nervous system, and patients with encephalitis or brain inflammation actually have an antibody-mediated cause of the disorder, differentiating it from other neurological conditions and other causes like infectious encephalitis. And since about 2005, 2006, there's been a real expansion in the number of target antigens that have been identified. Some of the common themes in these syndromes is that the pathogenic antibodies usually target extracellular cell surface epitopes of neurons and oligodendrocytes, rather than intracellular epitopes. These patients appear to be immunotherapy responsive. And also it's really been the advent of live cell-based assays as detection methods to identify these antibodies in patients' serum and CSF that have really helped to define the clinical relevance of these syndromes. So I've done a lot of work on looking at a particular type of demyelination that's distinct to multiple sclerosis, and it's called myelin oligodendrocyte and glycoprotein antibody-associated disorders, or MOGAD. And we first started looking at this in adults in 2013 and 2014, when we identified a distinct subgroup of patients who had bilateral optic neuritis and long involvement of the spinal cord, or longitudinally extensive transverse myelitis, resulting in blindness and paralysis that appeared to be clinically and radiologically very different from multiple sclerosis. And we found that a large proportion of these patients actually had IgG antibodies targeting MOG. Around the same time that we were doing this study, there was a number of groups internationally that also identified findings that corroborated this. We provide the National Diagnostic Service, and this is led by Associate Professor Fabienne Brulot at the Children's Hospital. And this is indeed the method of detection for all these antibody-mediated neurological syndromes, where the gold standard diagnostic test is a live cell-based assay, where human embryonic kidney cells are transduced or transfected to surface express the antigen of interest. Patient serum is incubated. This complex is then further incubated with a secondary fluorescent tagged antibody. And then you can use either flow cytometry or microscopy to identify the presence of co-localization and specific antibodies to these specific antigens, either in patient's serum or CSF. So since 2014, our group have been the lead investigators of the Australian and New Zealand MOG study group, and we have over 150 pediatric and adult neurologists, ophthalmologists and immunologists from 45 centres in Australia and New Zealand. And together we have created one of the largest international MOGAD cohorts of 500 patients. And it's really been this immense collaborative platform that's allowed us to perform our research, which I'll touch on going forward. I work with Professor Russell Dale, who's a pediatric neuroimmunologist and who performed a lot of the early work defining children with MOGAD as having a distinct syndrome to patients with children with multiple sclerosis due to a number of clinical features. And why is this differentiation important? Well, these conditions actually have divergent treatment pathways and divergent prognoses and outcomes. And patients with MOGAD who are misdiagnosed as multiple sclerosis and have MS therapies actually tend to do worse. So early identification is critical. So together we evaluated 60 relapsing patients with MOGAD, both adults and children. We confirmed that the most common phenotype in children is called ADEM, or acute disseminated encephalomyelitis. Both adults and children have a predilection for optic neuritis, or immune-mediated damage to the optic nerve causing blindness. And then some patients also have transverse myelitis and brainstem cerebellar involvement, etc. We were very interested in how do you expedite diagnosis of these patients in order to start the appropriate immunotherapy as soon as possible and improve their outcomes. And one of the features we looked at was the radiological differentiators. How at a first episode of optic neuritis can you say if a patient is going to have MOG antibodies, multiple sclerosis, or another antibody-mediated syndrome called Aquaporin 4 antibody-associated optic neuritis? When we studied numbers of patients with these three conditions, we found that patients with MS often had unilateral optic nerve involvement with short segments of the optic nerve involved, compared to the antibody-mediated syndromes that had bilateral optic neuritis with long segments of the optic nerve involved. However, the MOG antibody-positive patients often had very anterior optic nerve involvement. They had disc swelling clinically and radiologically that was not present in the other two diagnostic groups. In contrast, those with Aquaporin 4 antibodies had very posterior optic nerve involvement. This involved the chiasm and the optic tracts, and this wasn't present in the other two diagnostic groups. So there are clinical and radiological clues that can actually help identify this diagnosis early in the disease course. Due to our large collaborative platform, we were also able to pick up on expansion of the clinical syndromes associated with MOG. So not just optic neuritis and cord involvement, but it had been identified that some of these patients had seizures as well, overlapping with autoimmune encephalitis. And we were able to identify a number of patients who actually had seizures as the index central nervous system event, followed by more typical demyelination. And Professor Russell Dale and Sudarshini, who I also work with at Oxford, members of the International League Against Epilepsy Autoimmunity Task Force. And with our work, MOG is now included under the umbrella of autoimmune seizures in one of their more recent consensus papers. As part of my NHMRC Early Career Fellowship, I had the privilege of going to Oxford for 2 years for my postdoctoral fellowship. And there I was working with Professor Sudarshini. And I was interested in further evaluating some of our MOG antibody positive patients who not only had central nervous system involvement, but appeared to have inflammatory peripheral nervous system involvement. These patients had enhancement and thickening of the nerve roots exiting the spinal cord, and they had inflammatory neuropathies. So we set up a collaboration with Professor Simon Rinaldi and Alex Davis in Oxford to evaluate these patients in more detail and actually identified a proportion of these MOG patients have overlapping peripheral nerve antibody-mediated neuropathies with antibodies to neurofacin 155 and Caspar-2. So the clinical spectrum of these newly recognized conditions are expanding all the time. We found out that a number of these patients who relapse continue to have disability, particularly those with spinal cord involvement. Very few have complete recovery. And indeed, 60% of patients with relapses have deficits ongoing in one or more domains of vision, sensation, motor function, etc. We also know that some of these patients with optic neuritis have thinning of the retinal nerve fiber layer compared to this, which puts them at risk of sustained blindness. So really the early induction of remission is critical, and what treatment is used is very important. We tried to study these patients' response to treatment and identify that they respond very rapidly to corticosteroids, often with complete reversal of their disability. However, with attempts to wean the prednisone doses down or after cessation in the first few months after prednisone cessation, they have a big rise in relapses. So corticosteroids work very well. However, the long-term burden of steroids on metabolic and cardiovascular and bone health are not acceptable. So we looked at the effect of other immunotherapies such as intravenous immunoglobulin, mycophenolate, and rituximab, and identified that these particular treatments also reduce the annualized relapse rate during treatment, providing us with other options to treat these patients alongside corticosteroids. When I worked in Oxford with Professor Irani, that group had identified in 2009 an autoimmune encephalitis syndrome where antibodies target LGI1 on the cell surface of neurons. And this particular group had identified that they had a very distinctive seizure phenotype called fatiobrachial dystonic seizures early on in disease course. And without adequate treatment, these patients go on to develop long-term cognitive impairment. And Sudarshini's group had identified that a delay to start the immunotherapy reduced the chance of seizure cessation and increased the chance of developing long-term cognitive impairment. So he was interested in us evaluating the specific therapeutic efficacy of different immune treatments in patients with LGI1 encephalitis. Now, this condition is not particularly common, and interestingly, international therapeutic practices vary widely. And so in Australia, we're lucky that we have anti-CD20 monoclonal antibodies like rituximab available via drug committee approval in many centres. This is not the case in the UK. And so a lot of these patients have this incredible steroid burden and all the adverse effects associated with it, and attempts to wean the steroids result in relapses. So we established an international multi-center collaboration of over 20 institutions internationally, including Australia and UK leading this. And we have now recruited and phenotyped over 250 patients with LGI1 autoimmune encephalitis, including 70 patients treated with rituximab. And we've developed detailed clinical, therapeutic, and outcome data. And we are currently working with this data analysis to develop consensus therapeutic guidelines regarding the timing of treatment to reduce relapses and improve outcomes. One of the other arms of my research is looking at mechanisms of action of pathogenic antibodies in these various syndromes, and also what triggers autoimmunity in these various syndromes in order to try and identify therapeutic targets. So Fabian Brulot and Russell Dale had previously demonstrated that purified MOG IgG induces natural killer mediated killing of MOG expressing cells. Other groups internationally have shown the importance of complement dependent cytotoxicity in MOGAD. And our group also showed that purified MOG IgG results in disruption of the oligodendrocyte cytoskeleton compared to healthy control IgG. And this appears to be reversible to some degree, suggesting the immunotherapy responsiveness. I was interested in specifically evaluating which stages of B cell development produce these pathogenic antibodies that cause the problems. So we are well aware that bone marrow development of B cells are important, and there are a number of central tolerance checkpoints in the bone marrow that reduce the risk of autoreactivity in healthy patients. When these lymphocytes egress from the bone marrow into the circulation as new immigrant or transitional B cells and then naive B cells, the traditional dogma is that they encounter an antigen, they have germinal center interactions with T helper cells, and they develop into memory B cells and plasmablasts that are supposed to be responsible for producing the majority of these pathogenic antibodies. However, we see some patients where monoclonal antibody therapy targeting these groups do not seem to work. So in Oxford, along with Professor Sudarshini and Dr. Paddy Waters and another postdoc I worked with, Dr. Denise Actonese, we evaluated in patients with Aquaporin 4 associated demyelination, which stages of B cell development could be particularly problematic in producing these pathogenic antibodies. So we collected peripheral mononuclear cells in the blood from patients with high titer Aquaporin 4 antibodies, single cell sorted these into 96 well plates, performed a 26-day culture under proliferative conditions with cytokines, and at the end we had clonal populations of B cells in single wells that we could actually identify by testing the supernatant with cell-based assays whether or not they were producing the pathogenic Aquaporin 4 antibodies. In those wells that were positive, we generated a protocol to develop monoclonal antibodies that we could transfect into HEK cells and then purify these monoclonal antibodies from aquaporin for producing specific B cells. So we identified that, interestingly enough, in patients with aquaporin 4 associated demyelination, it was actually very early on in B cell development rather than at the memory B cells, where they had a huge increase in the number of aquaporin 4 producing B cells. And this was very different to healthy controls and demonstrates a breakdown in the central and peripheral B cells tolerance mechanism in these patients compared to healthy controls. With the monoclonal antibodies that we've generated, we are now able to evaluate a number of different features from each of these stages of development, like looking at the binding affinity and preferential epitope binding sites on the aquaporin 4 molecule, looking at methods of how these result in cell death due to complement-mediated cytotoxicity, and also injecting purified monoclonal antibodies into murine or mouse models to show evidence of astrocyte destruction. So in conclusion, some of the main themes of our research program have been that really careful clinical and radiological phenotyping allows us to differentiate these patients who have a reversible brain injury due to pathogenic antibodies from those who have other etiologies, and that we know that early treatment with immunotherapy improves outcomes, but the diagnostic and therapeutic guidelines in these disorders are yet to be developed. And really, due to the relative rarity of these conditions, multi-center national and international collaboration is critical to move the field forward. And it is the understanding of what triggers autoimmunity in these patients, also how these antibodies affect their end target damage, that might allow us to identify therapeutic targets for patients who don't respond to conventional immunotherapy. I'd like to thank all of those I collaborate with whom I mentioned, as well as our national study groups. Thank you.